Chapter 38 discusses disorders of the hepatobiliary and exocrine pancreas. So first we're going to talk about the functions of the liver and the manifestations that occur when its function is altered. One big piece of the liver function is its production of bile salts. When the liver's ability to produce bile salts is disturbed, it leads to things like malabsorption syndromes, specifically of fat and fat-soluble vitamins. So fat-soluble vitamins are things like vitamin A, vitamin D, vitamin E, and then of course fats. And so then those fats, when they aren't absorbed, lead to a condition called steatorrhea, which refers to fat in the stool. Another major function of the liver is to eliminate bilirubin. Bilirubin is a byproduct of the breakdown of red blood cells within the body. When bilirubin cannot be excreted efficiently, it causes an increase in serum bilirubin because it's not being removed from the bloodstream, and that causes the characteristics of yellowing skin and eyes that we associate with jaundice. The liver also is important in the metabolism of steroid hormones. So it can lead to things like gynecomastia, which is breast formation in men. It can lead to elevated cortisol levels. It can lead to hyperaldosteronism. The liver is also very important in the metabolism of drugs. So when the liver is damaged, we see a decreased metabolism of drugs and decreased levels of protein binding because the liver failure leads to a reduced overall level of serum protein. And so often we need to make adjustments to drug dosing levels to compensate for these two issues. The liver also is important to carbohydrate metabolism. Hypoglycemia may develop in patients because they are unable to go through the processes of glyconeogenesis when the liver is impaired. Fat metabolism is also impaired. The liver is important in the synthesis of lipoproteins, and so patients with liver function get altered serum cholesterol levels. And finally, one of the really important functions of the liver is protein metabolism. And so some of the clinical manifestations we see when protein metabolism is altered are things like elevated blood ammonia levels, decreased plasma proteins with edema formation, a tendency to bleed due to the loss of clotting factors as well. And we'll talk about some of the different ways that we assess overall liver function. Serum liver enzymes are one very important way. So that's things like serum aminotransferase levels, ALT or AST. Those assess injury to liver cells. ALT is a little more specific to the liver. AST can also be elevated from things like damage to other organs. But they are very important serum liver function markers. We also can look at protein levels and prothrombin levels. Those are often reduced in liver failure. We can look at serum bilirubin levels, GGT and alkaline phosphate. Those measure hepatic excretory function. We can look at an ultrasound, a CT, or an MRI of the liver. They can evaluate the different liver structures and look for things like, enlargement or changes to the overall structure. We can do angiography, where we inject contrast dye into the blood supply around the liver to look for things like hepatic or portal circulation. And we can do liver biopsies, where we take a sample of the liver tissue itself for microscopic examination to look for things like fibrosis, toxicities, to look at things like cancer formation. But those are essentially the main assessment tools that we use for liver function. So let's talk a little bit about liver bile. Bile is produced by the liver and has many important functions. The liver produces about 500 to 600 mLs of this yellowish green bile every day. It contains water, bile salts, bilirubin, cholesterol, and certain byproducts of metabolism. The main function of the bile salts that are contained within the bile is to aid in the digestion and emulsification of fats that we eat. So that bile containing bile salts is released into like the duodenum and then transfers into the ileum, especially when someone eats, so that it can help with that emulsification and absorption of fat. So bile salts enter the intestine, and after they are used for that emulsification, they are then reabsorbed back up into the portal circulation from the GI tract, where they move back into the liver cells and are recycled. So you can kind of see that in the picture here. The liver is producing bile that contains bile salts. Much of that is actually stored also in the gallbladder. So we have storage here that can also be released, especially when we eat. So that's what kind of stimulates that release of bile. But then the bile salts travel through the common bile duct and they end up in the duodenum, where they can mix with fat to emulsify it. And then they're reabsorbed up into the capillary beds, where they're recycled back into the liver to kind of start the whole process again. So one condition that can occur with the production of bile is something called cholestasis. And that is when we have an overall decrease in the flow of bile through the liver. So you just kind of saw how that regular flow goes, produced in the liver, transfers down, some stored in the gallbladder, and the rest into the GI tract, where the bile salts are reabsorbed. Beyond the bile salts, everything else is kind of excreted out through the intestines. So in cholestasis, all that bile that's typically flowing through the liver and out just sort of sits there. It becomes kind of stagnant and doesn't move through as effectively. So that's the result of that is decreased secretion of water, bilirubin, and bile acids by those hepatocytes. So that normal excretion that we get, where we get water and bilirubin and bile acids to move through and end up in the intestine, isn't really happening. So everything is just kind of like sitting in the liver and starting to back up. So bilirubin, cholesterol, bile acids, all of those things start to then further accumulate in the blood because they're not being transferred into the bile. And so that leads to things like elevated cholesterol levels in the blood. It leads to things like jaundice because we have excess bilirubin. And it also can lead to, like one of the common signs is like itching because some of these different components are starting to build up within the skin. So here are some causes of intrahepatic biliary disease. So some of the things that can cause this like stagnation of bile flow or difficulty producing bile within the liver itself. One major cause is primary biliary cirrhosis. This is an autoimmune disease that destroys the intralobar or the intrahepatic bile ducts, and that leads to cholestasis. So the bile ducts themselves are being destroyed. Bile isn't moving through as readily, and it leads to cholestasis. Another cause is primary sclerosing cholangitis or secondary biliary cirrhosis. PBC, or primary biliary cirrhosis, is this progressive scarring and destruction of liver tissue, and that disorder actually eventually leads to liver failure, and most of the patients with PBC end up needing a liver transplant. So again, here are some of the symptoms of that intrahepatic biliary disease. I kind of mentioned these a little bit already, but we'll go over them again. Some of the early symptoms are unexplained pruritus or itching. So if someone has intrahepatic biliary disease and cholestasis, they may not know, this is happening, but then they, may experience kind of all of this like overall sort of itching that just doesn't go away. They may also lose weight and be progressively fatigued. As the disease progresses, some of the later symptoms are dark urine and pale stools. Dark urine is being caused by spillover of bilirubin into the urine, and pale stools is being caused by the lack of bile containing bilirubin ending up in the stool. So it changes the overall color from kind of a dark brown to a really kind of pale color. And people may also experience jaundice. Jaundice is a late manifestation of this disorder, as are the other signs of liver failure. Other things that might occur is an elevation in serum alkaline phosphate levels, especially in people with PBC. So let's talk a little bit more about jaundice and what it is and why it occurs. So jaundice is, again, that kind of distinctive yellowing color that people get to their skin. And it's caused by an increase in the amount of bilirubin in the serum. And there are a lot of different things that can increase bilirubin, but essentially bilirubin is a byproduct of the breakdown of red blood cells. So one thing that can cause jaundice is when someone has excessive destruction of red blood cells. So in that case, they may have, normal liver function, normal ability to excrete red blood cells, but there are so many of them being broken down so quickly that it's sort of overwhelming the ability of the system in the liver to get rid of them. So they do start to eventually build up. So excessive destruction of red blood cells is one potential cause of jaundice. Another is impaired uptake of bilirubin by the liver cells. So if liver cells are unable to take that bilirubin up, it starts to back up and remain in the serum, causing jaundice. And another is something called decreased conjugation of bilirubin. There are two types of bilirubin in the system, conjugated and non-conjugated. As bilirubin, as red blood cells break down, and turn to bilirubin, they float around in the plasma as free bilirubin and sometimes protein bound. And we call those that unconjugated bilirubin. Unconjugated bilirubin cannot be excreted. It needs to be conjugated by the liver to be able to be excreted from the body. So if we have a decrease in the conjugation of bilirubin in the liver, we'll have more unconjugated bilirubin that can't be excreted, and that starts to build up in the serum, causing jaundice. And another cause of jaundice is obstruction of bile flow in the canaculae of the hepatic lobes or in the intrahepatic or extrahepatic bile ducts. And so if, even if we're, maybe we're still, creating bile normally in the liver, but if it is being blocked kind of right here through the bile duct and can't travel into the intestine, it can start to back up. And then we get an elevation of bilirubin in the liver and then back into the rest of the serum system. Okay. So there are a lot of different categories then of jaundice that are really talking about kind of where in that process of removing broken down red blood cells this is happening. So there are prehepatic causes. So a major cause is excessive hemolysis of red blood cells. So prehepatic are the things that cause a massive increase in the destruction of red blood cells or a big increase in the amount of unconjugated bilirubin in the serum. So in prehepatic cases of jaundice, there's mild jaundice. If we look at serum levels of unconjugated bilirubin, those are elevated. But things like the stool remains normal color because the liver is still producing adequate amounts of bile. So the stool stays normal. We still have the same amount of that stuff kind of being released into the intestines, if not more, but we just can't kind of keep up. And usually in those cases, there is no bilirubin that starts to spill over into the urine either. Intrahepatic jaundice are caused by disorders that directly affect the ability of the liver to remove bilirubin from the blood or conjugate it so it can be eliminated in the bile. So in intrahepatic causes, both conjugated and unconjugated bilirubin are elevated. The urine usually gets dark in color because of bilirubin in the urine, and serum alkaline phosphatase is elevated. And the final cause of jaundice is posthepatic, and this occurs when that bile flow is obstructed between the liver and the intestine. So in posthepatic cases, conjugated bilirubin levels usually are elevated. The stools end up being kind of this pale clay color because of the lack of bilirubin in the bile. And the urine is dark as bilirubin spills into it. Levels of serum alkaline phosphatase are very elevated, as are levels of aminotransferase in these cases as well. So then we'll talk about some of the hepatotoxic disorders, or things that can cause toxicity to the liver. One major cause is injury from drugs and toxins. The liver is central to the metabolic disposition of essentially all drugs and all foreign substances. The liver is receiving all of this blood from places like the GI tract and other portions of the circulation like the spleen. And so it is just kind of constantly washed in all of the toxins and drugs and things that we take. So it is highly sensitive to metabolic damage from these things, like circulating through it. Drug-induced liver toxicity is a potential complication of many medications, and I'm sure you've talked about that in your pharmacology class and noted that there are a lot of medications that carry hepatotoxicity as a potential side effect. So there are many different types of reactions involved in hepatic detoxification and metabolism of things like drugs and toxins. Some of these are what we call phase one reactions. These involve chemical modification or inactivation of a substance like a drug or toxin. So these are things like maybe what you've heard of is cytochrome CYP or cytochrome P450 system. So genes produce enzymes responsible for these phase one reactions, and their activity can be induced or suppressed by things like alcohol consumption, environmental toxins, or by other drugs. So again, in a phase one reaction, some chemical mediator um, like cytochrome P450 that's produced by the genes goes in and modifies or inactivates different substances. And if there is a disruption in the activation of that enzyme, it can change the way drugs are metabolized. In phase two reactions, this involves the conversion of lipid-soluble substances to water-soluble derivatives. So when things are lipid-soluble, we can't excrete them through the kidneys. So one of the things that the liver often does is it converts fat-soluble drugs to water-soluble ones so that they can be moved out of the system. So in phase two, some drugs and toxins need multiple phases. So lipid-soluble substances would accumulate in the body if this conversion did not happen. So in general, the conjugates are more soluble than the parent compound and are pharmacologically inactive. So once that liver changes something that's fat-soluble to water-soluble, that new substance that it makes is usually pharmacologically inactive and then leaves the system. In phase three reactions, this involves the secretion of drugs, drug metabolites, or drug conjugates into the bile. So sometimes the breakdown of drugs, those kind of conjugates or things that are left over after it's metabolized are just released into the bile and then go out through the intestine and into the feces. So there are a lot of different host factors too that contribute to susceptibility of drugs to induce liver disease. As we mentioned, a lot of drugs have the potential for liver damage, but obviously they don't produce liver damage in every single person that takes them. So there must be something about the host who takes these drugs that makes them somewhat more susceptible to this damage. So some people have a genetic predisposition, maybe they lack some of the genes that produce some of the enzymes responsible for drug metabolism and breakdown. And so that may make them more susceptible to drug-induced liver disease. There are also age differences. As people age, their susceptibility to toxicity from drugs increases, as do those who are very young, who maybe have immature liver function. Patients with underlying chronic liver disease are also much more susceptible to drug-induced liver disease. People who have poor diets, things like high in fat and cholesterol, or patients who consume significant amounts of alcohol can also be more susceptible. People who have things like fatty liver disease caused by a significant increase in abdominal fat linked to like metabolic disorders and poor diet. And finally, the use of multiple interacting drugs. So if someone's taking a lot of different medications, many of which have the potential to cause hepatotoxicity, they are far more at risk for this happening than someone who isn't taking multiple medications. Drug-induced liver disease is responsible for more than 50% of all cases of acute liver failure in the United States. And 10% of those are actually caused by things like herbal supplements that are really unregulated and people often take without the knowledge of, physicians, so that we can't necessarily track their interactions with other hepatotoxic drugs. So that's an important kind of thing to watch for when you're doing medication reconciliation or having discussions with patients about herbal supplements. They are not always a benign substance and can cause some really significant issues. Early identification of the cause of drug-induced liver disease is really essential because the withdrawal of that drug may be curative and stop the liver damage in those cases. So there are a lot of different ways to that drug-induced liver disease can happen. One is direct hepatotoxic injury. So things like acetaminophen, antimicrobial agents, some psychotropic agents, some of our lipid-lowering agents, NSAIDs, those are the most common drugs associated with acute liver injury or that direct hepatotoxic injury. Idiosyncratic reactions are reactions that are unexpected and not related to the dose. And so we think maybe sometimes those are probably maybe allergic reactions to a drug. They're just very unexpected, right? Like somebody hasn't taken a large dose of a medication. The risk of hepatotoxicity was relatively low based on dose and drug, and all of a sudden now that's what we see. So we think probably allergic reaction maybe to blame there. Cholestatic reactions, cholestatic drug reactions result in decreased secretion of bile or obstruction of the biliary tree, leading to liver damage when that bile kind of stops flowing through the liver. And some drugs produce a more indolent or slowly progressing form of liver damage that closely resembles things like chronic hepatitis. Early identification of drug-related chronic hepatitis is often really difficult. Patients may develop cirrhosis before the hepatitis is even diagnosed. And then what the problem then is that identifying the responsible drug can be really difficult because they may have started that drug long before the symptoms occurred. Especially if someone has been like consuming alcohol or taking several drugs in the meantime, really boiling it down to the exact cause in those cases can be very difficult. So now we're going to talk about the causes of hepatitis, and hepatitis is inflammation of the liver. So there are autoimmune disorders that can cause hepatitis. Reactions to drugs or other toxins can cause hepatitis. There are many infectious disorders that can cause hepatitis, like malaria, infectious mononucleosis, salmonella, and amoebiasis. Hepatotropic viruses that primarily affect liver cells or hepatocytes are also an important cause of hepatitis. So these are things like hepatitis A, B, C that we'll talk about. And these cause direct cellular injury as well as induction of immune responses against the viral antigens that kind of directly injure our liver cells. So we're going to talk a little bit more about viral hepatitis. So viral hepatitis is inflammation of the liver caused by viruses that primarily affect liver cells. And we're going to focus on hepatitis A, hepatitis B, and hepatitis C in our discussion. There's also hepatitis D and E that typically occur together, but we're going to focus on those first three. They all differ in their modes of transmission, in their incubation periods. They also differ in their mechanism of infection, the degree to which they cause infection and liver disease, and also the chronicity of the liver damage. And then some can evolve to a carrier state, and many are just cleared, and some are just cleared by the immune system. These diseases can cause damage to liver cells either via direct cellular injury, where the virus itself is injuring the cell, or when the virus enters the system, it initiates an immune response that leads to further damage of those liver cells. So we're going to start with hepatitis A. And hepatitis A is a form of hepatitis that is contacted or transmitted via the fecal-oral route because people shed hepatitis A virus in the stool. Hepatitis A is usually benign and self-limited for most people. Most people clear this infection. It usually does not become chronic or severe, but in some limited cases, it can become more severe. It has a really brief incubation period, so people usually become sick within 14 to 28 days after infection. The usual sources of hepatitis A are things like drinking contaminated water, eating shellfish that were living in infected water. Those are common routes. Can also be transmitted maybe through restaurant workers with the disease who haven't washed hands before preparing food. We often look for Hep A or are conscious of Hep A when patients have traveled to other countries that may not have good sanitation measures to keep things like Hep A out of the water and food supplies. We often see an abrupt onset of symptoms that are things like fever, malaise, nausea, anorexia, abdominal pain, dark urine, and jaundice. The overall severity of hepatitis, how sick people get, increases with age. The older you are at the time of infection, typically the more sick you get. Hepatitis A infections in children actually rarely cause symptoms. They usually clear the virus without really knowing they're sick, but they are able to shed and spread Hep A, so they are actually a really important kind of piece in the puzzle of the spread of Hep A, because they're often spreading it without knowing it, and the way that kids are with things like hygiene practices and post-bathroom sort of habits can really lead to an extensive amount of spread. So people like daycare workers who work closely with really young children are also at kind of like an elevated risk of Hep A. There is an immunization available for hepatitis A, but we typically only give it to maybe people who are traveling to areas with high risk, or people who are at high risk of contracting Hep A and or transmitting it. So it is not a vaccine that we give to the entire population. Hepatitis B can produce acute hepatitis. It can produce chronic hepatitis. It can also progress to cirrhosis. It can cause hepatic necrosis, and it can lead to a carrier state when infected with this virus. It is transmitted via bloodborne transmission. It has a longer incubation period and can produce illness that is much more severe than what we see in hepatitis A. People at high risk of contracting hepatitis B are people who are IV drug users, people with multiple sex partners, or men who have sex with men. Healthcare workers are also at an increased risk of hepatitis B infection due to bloodborne pathogen and needle stick exposure. Immunization is available for hepatitis B, and it is widely encouraged. It's recommended for all children between the ages of 0 to 18, or for any unvaccinated adults. And so that's the best method that we have to control the spread of hepatitis B is widespread immunization against it. And finally, we talk about hepatitis C. There are many people around the world living with chronic hepatitis C infections. It is relatively common worldwide. And it is also the leading cause of the need for liver transplantation in the world. Hepatitis C is spread via sexual contact. It is spread by injecting drugs. It can be transferred to infants during the birthing process. It can also be contracted through healthcare exposure, and it can also possibly be spread through things like tattooing or body piercings. It has a wide variety or a wide variation in incubation period, anywhere from 2 to 26 weeks. And 80% of people infected with hepatitis C will develop a chronic form of hepatitis. Approximately 20% clear the virus, but the vast majority move into a chronic hepatitis state. There's a wide diversity of genotypes that contribute, a wide diversity of genotypes in hepatitis C too, and that's probably why it's so pathogenic, why it leads to so much kind of infection, and especially in chronic nature, because all of those different genotypes allow it to escape the actions of the host immune mechanisms and also antiviral medications. And that has also led to hepatitis C being very difficult to develop a vaccine against. Again, because there's so many different types of Hep C, you can develop a vaccine and it may work against a couple of them, but there are so many others that could become infectious. So it has been very difficult to do anything that really works well for treatment and prevention of Hep C for those reasons. So really our best prevention of Hep C is identification of high-risk types of behaviors and trying to prevent those behaviors. Let's see. Chronic infection that occurs from Hep C can cause things like cirrhosis, end-stage liver disease, and hepatocellular cancer. So it can lead to very serious problems in patients. Things like age at time of infection, male sex, immunocompromise, a concurrent infection with hepatitis B, alcohol consumption, the use of hepatotoxic infections. All of these things can further increase the risk of serious consequences from a hepatitis C infection. So chronic viral hepatitis is the cause or is the end result of any hepatitis infection that can become chronic in nature. So usually hepatitis B and C, and in some cases hepatitis D. So hepatitis A, as we mentioned earlier, is not really a significant cause of chronic viral hepatitis. But chronic viral hepatitis is an inflammatory reaction of the liver that lasts for more than 3 to 6 months. And it's characterized by signs and symptoms of fatigue, malaise, loss of appetite, and occasional jaundice. We also will see elevated liver enzymes in these patients. And there's really no simple and effective treatments for chronic viral hepatitis. It's relatively difficult to treat with any degree of success. There are some interferon drugs and some antiretroviral agents which may help. Maybe in up to about 40% of patients, we may see some regression of the disease. But often if it leads to cirrhosis and end-stage liver disease, liver transplantation is really the only treatment available at that point. And often the graft will become reinfected with the hepatitis infection. Even if it does become reinfected, we see a lot of slowing of the progression of the disease, but reinfection happens nonetheless. The excessive use of alcohol can also lead to liver disease. We call it alcoholic hepatitis. That's the intermediate stage between fatty changes and cirrhosis. Fatty liver disease is usually what we see first, and that's an accumulation of fat in hepatocytes. It's a condition called steatosis. Fatty liver disease can actually also happen from patients who don't drink a lot of alcohol. It can be caused by metabolic disorders and obesity, especially excess abdominal obesity can lead to fatty liver disease. But again, it can also be caused by alcohol induced liver failure. Then it progresses to alcoholic hepatitis, again, that intermediate stage between fatty changes and cirrhosis. And that can finally lead to the condition of cirrhosis. And that is the result of repeated bouts of drinking, related liver injury, and designates the onset of end-stage alcoholic liver disease. And that's kind of the progression that we see. It's estimated that there are 14 million alcoholics in the United States, and about 10% of alcoholics will develop cirrhosis with continued heavy drinking. In that fatty liver stage, that's a really early stage. Usually there's no symptoms, and if drinking stops or whatever the causative agent stops at that point, usually that damage is reversible. Hepatitis is when we start to see symptomatic kind of nature occur. So this stage is usually characterized by hepatic tenderness, pain, anorexia, nausea, fever. These patients often develop jaundice and they may develop ascites. And that's, the next step is really liver failure. Okay. These things may be reversible even in the alcoholic hepatitis stage, but they can also rapidly progress. And rapid progression often has a relatively high mortality rate. So in alcohol-induced liver disease, we see this occur because of the metabolism of alcohol itself in the liver. So through those metabolic reactions, that's largely what's causing the liver failure to occur. So during ethanol or alcohol metabolism, this generates an excess of something called NADH, which is thought to contribute to the liver damage that often accompanies excess alcohol consumption. So when metabolizing alcohol, we're using up something called NAD that is also needed for a lot of other metabolic processes so that we start getting things like lactic acid buildup because we can't break it down, or we start to get hypoglycemia because we're depleting all of our glycogen stores. Prolonged and excessive alcohol ingestion also results in enzyme induction and increased activities of the MEOS system. And one of the most important enzymes of the MEOS system is a member of the CYP450 system that oxidizes a number of compounds, including things like drugs, toxins, vitamins A and D, and other carcinogenic agents. So increased activity of this system further enhances the susceptibility of people with heavy alcohol consumption to the hepatotoxic effects of other substances. So those kind of major things are the reason why that alcohol leads to the destruction of the liver. So when cirrhosis of the liver occurs, what this essentially is fibrotic or fibrosis replacement of hepatic tissue. So we have good, healthy hepatic tissue that starts to fibrose, and it can no longer, do the same like functions that it was meant to do. And so then we get this loss of overall liver function. Nodules may form within the liver as it fibroses. And these nodules can compress things like the hepatic vein, and this slows down blood flow out of the liver. This leads to something called portal hypertension that we'll talk about. It leads to all this portosystemic shunting that we'll talk about, and it leads to cholestasis, which we referred to before as that kind of overall slowing of the movement of bile through the liver. So patients with cirrhosis will experience things like weight loss, although sometimes that's masked by a condition called ascites, which is an accumulation of an excessive amount of fluid in the abdominal cavity, which we'll talk about in a couple slides. They also develop weakness, anorexia, diarrhea, and constipation can occur. They get hepatomegaly, which is the enlargement of the liver. They can develop jaundice, abdominal pain, and some of the major issues, again, that we'll talk about after this are portal hypertension, ascites, esophageal varices, and splenomegaly. Cirrhosis, as we mentioned, is often associated with alcoholism, but it can also develop in the course of other disorders like viral hepatitis, toxic reactions to drugs and chemicals, biliary obstruction. So while we closely associate cirrhosis with alcohol, there are several other causes of cirrhosis. So just, I think a lot of the time we see cirrhosis and we assume it's alcohol induced, but that is not always the case. So make sure you're aware of that underlying kind of cause of cirrhosis. This picture I pulled directly out of your book. It just shows some of the different manifestations of liver failure. Many we already talked about, like jaundice. They can also get something called hepatic encephalopathy. All of those toxins and metabolic things that should be broken down in the liver, specifically things like ammonia, start to build up in the system, and that can cause inflammation of brain tissue. That's what encephalopathy is, encephalitis, and they can get things like confusion, drop in level of consciousness. We're going to talk about esophageal varices, spider nevi, or all these like little periumbilical caput medusa. These are induced by, some of it is induced by a loss of like coagulation factors that leads to spider nevi. It leads to things like purpura. But these periumbilical caput medusa, which is like all these little veins that form on the surface of the abdomen, this happens because of the blood flow, where the blood can't flow through the liver, so it starts to back up into all these like little, what we call collateral veins, and so they build up on the belly. You can kind of see those. Muscle wasting occurs because of protein synthesis. Ascites is this kind of buildup of fluid in the belly, so they get these kind of big protuberant bellies. Hemorrhoids often occur, again, because of all the backup of blood through the portal circulation. It starts to back up into the, it starts to shunt into these vessels that supply blood to the rectum, and that can cause hemorrhoids. We can get testicular atrophy because of the effects of the metabolism of different steroids within the body, as well as gynecomastia. Edema often forms because these patients have reduction in oncotic pressure because of lower albumin levels. And we'll talk about esophageal varices, but those are outpouchings of the veins within the esophagus. So again, manifestations of liver failure, hematologic disorders are really important here. So things like coagulation factor loss because of the loss of protein metabolism. But we're going to also talk about some of the hematological disorders that can happen in liver failure because of sequestration of blood components in the spleen. Endocrine disorders often occur, so things like hypoglycemia because of the lack of gluconeogenesis through the liver. things like gynecomastia and testicular changes because of sex hormones, hyperaldosteronism. Those are just some examples of endocrine disorders that can occur. There's a lot of skin disorders, as we just mentioned, things like jaundice, things like changes to the blood vessels in the skin. Itching is relatively common. Hepatorenal syndrome is another issue that can occur where liver failure starts to lead to renal failure. It can kind of occur together. And then, as we mentioned, hepatic encephalopathy, where some of those toxins that should be cleared by the liver start to build up in the blood, leading to inflammation and confusion in our patients. So we're going to talk a little bit more about the portal circulation because this is going to lead to our discussions on some of the major complications of liver failure like ascites, splenomegaly, and esophageal varices. So within the portal circulation, 75% of the blood that enters the liver does so via the valveless portal vein. We also have a hepatic artery, but it only supplies 25% of the blood supply to the liver. The vast majority of the blood coming into the liver is coming in through the venous system. And this is a really kind of different way of circulation. The liver is really the only organ that has this huge amount of blood being delivered through the veins. Most tissues in the body get blood delivered via the arteries and it goes away through the veins. And the circulation through the liver is very, very different. Okay. So that blood that's coming in through the portal vein, and you can see the portal vein right here. It's this major vein that then branches to supply all of this venous blood directly to the liver. And that blood is coming from places like the digestive tract and all the other major abdominal organs, including the pancreas, which is right here, and the spleen, which is right here. And so again, there's that portal vein supplies the blood, but you can see all of these venous branches that are coming from the GI tract, the pancreas, and the spleen. Also, from the gastric artery that are emptying into the portal vein and then coming into the liver itself. Okay. The portal blood supply carries nutrients and toxic materials that have been absorbed from the intestine and also from blood cells and their breakdown products from the spleen and insulin and glucagon from the pancreas. So all of those components coming from those organs are then making their way up into the liver so that it can do things like, glyconeogenesis. It can remove toxic substances. It can break down or metabolize carbohydrates, fats, and proteins. So that's a really important way that the liver performs all of its functions, is to pick up all that blood from all those different organs. And then the venous outflow from the liver is carried by the valveless hepatic veins into the inferior vena cava, just below the level of the diaphragm. So here's the inferior vena cava here, and the hepatic veins emptying out into it. So that blood empties through the portal vein and it goes through all these little tributary kind of venous pieces of circulation. So it kind of sits in the liver for a long time, which is helpful because that's when all of the kind of filtering of all of those components out of the blood occurs. And then eventually it dumps itself into the inferior vena cava so it can go back up to the heart. But a pretty low pressure system by design, again, to increase kind of that filtering time of all that blood through the hepatic circulation. The liver can also store a lot of blood. It can store about 500 to 1,000 mLs of blood at any given time. Can actually move blood out of storage if there's, times of like low circulating volume as well. And this is also why, remember when we talked about right heart failure, that increases the pressure in the vena cava, that's why we see blood back up into the liver in right heart failure as well. Again, because of that kind of venous to venous low pressure system that we see through the portal circulation. But the way that blood moves through the portal circulation is an important reason why we see things like portal hypertension in patients with liver failure. So portal hypertension can lead to three major manifestations: ascites, esophageal varices, and splenomegaly. So when the pressure within the portal vein system starts to increase, it increases the pressure in the peritoneal capillaries. So all those little capillaries within the peritoneal cavity start to increase in their pressure. And then fluid, because of that increased pressure, starts to leak across the capillary membrane, and it starts to accumulate inside the abdomen. And that's what we call ascites. It can also lead to something called post-systemic shunting of blood, where we develop all these little collateral channels to start to kind of like make new blood vessels to reduce the overall pressure. And that's what leads to, remember, that caput medusa, or all those little blood vessels that show up on the abdomen. It can lead to things like hemorrhoids and esophageal varices. And it can also cause hepatic encephalopathy, because when that blood is being shunted away from the liver into other areas of the circulation, it can't be filtered in the same way that blood through the liver is. And so that's all this unfiltered blood that contains kind of like all these toxins that continue to circulate, and that can lead to hepatic encephalopathy. And then splenomegaly occurs when blood backs up into the spleen. The spleen stores a lot of blood products like red blood cells, white blood cells, platelets. And if the blood is backing up, those components of blood get like trapped in there. And so that leads to things like anemia, leukopenia, thrombocytopenia, and bleeding. In alcoholic cirrhosis, which is the major cause of portal hypertension, bands of fibrous tissue and fibrous nodules also start to distort the architecture of the liver, and that further increases the resistance of portal blood flow leading through the liver, making portal hypertension even worse. So first we're going to focus on the disorder of ascites. So ascites is a fluid accumulation within the peritoneal cavity. So you can kind of see that here, right? Here's your peritoneal cavity with all your organs, and all of this free fluid is just starting to kind of collect around in that abdominal cavity. It is a late stage manifestation of cirrhosis and portal hypertension. It is not unheard of for patients to accumulate up to 15 liters of fluid or more within the abdominal cavity. Patients can become very uncomfortable, very distended. It causes dyspnea because of this upward pressure on the diaphragm and the lungs. It causes insomnia because people can't breathe. And it also can cause a lot of mobility difficulties. These patients have trouble getting around and walking because they have all this fluid. And it also it's a significant cause of the loss of independence for many of these late stage liver failure patients. And it's caused primarily by portal hypertension. So that portal hypertension causes an increase in the pressure in all of the peritoneal capillaries, and so they start to leak fluid across. And also, as you recall, levels of albumin are low in patients with liver failure because of the loss of protein packaging functions of the liver. And so that reduction in circulating protein leads to a further reduction in what we call oncotic pressure. And remember that oncotic pressure is kind of that pulling pressure. It's pressure within the blood vessels that helps to hold fluid in that vascular compartment. And so if albumin levels drop, we don't have that good pulling pressure, and so it leads to further leakage of fluid out of those capillary beds into the abdomen. Another thing that happens because all this fluid is starting to move into the abdominal cavity, we call that third spacing, right? And so patients still have all this fluid on board, but it's not in the vascular space. So they really have like low circulating vascular volume as this fluid leaks out. And remember, when you get low circulating volume, that stimulates the kidneys to hold on to more sodium. So these patients get sodium retention. And that low volume also stimulates the RAS system, which further leads to more sodium and water retention. And that retention of sodium and water makes the ascites worse. Okay. So the treatment of ascites is maybe some dietary restrictions of salt. We can also give diuretics to try to reduce the amount of fluid being retained. But if fluid starts to accumulate in the abdomen, we can do a procedure called a paracentesis. This picture depicts a paracentesis where we take a needle and just insert it through the skin into that peritoneal cavity. and then we just drain the fluid out into a container. We usually try to do maybe 5 liters or so max at a time because that removal of fluid can lead to a lot of like kind of a sudden reduction in abdominal volume, which can then lead to a sudden movement of more fluid out of the vasculature into that compartment. So if you suddenly removed every bit of fluid in that vascular or in that peritoneal cavity, you could get a massive shift of fluid out of the vascular space to almost like replace that volume that you removed. So we try to limit the amount of fluid we remove at a time. And then we also often give what we call volume expanders, usually albumin intravenously to try to further like hold the fluid in the vascular space when we remove it from the abdominal cavity. Um, Patients with liver failure may have paracentesis procedures done frequently. I've taken care of patients in this state who come in almost weekly to have abdominal fluid removed to make them comfortable. Another possible side effect of portal hypertension is something called splenomegaly, or enlargement of the spleen. So when blood starts to shunt into the splenic vein because of portal hypertension, and this causes the spleen to progressively enlarge. So here's the spleen in splenomegaly, and here's the splenic vein, and it comes directly off the portal vein. And so as the liver starts to fibrose, blood can't freely travel through it. It starts to back up into the portal vein. The pressure within the portal vein increases, and now all this blood starts to back up and sit and become what we call sequestered within the spleen itself. Okay. And remember, the spleen stores many of our blood elements, so things like platelets, red blood cells, white blood cells, and they become sequestered or trapped within the spleen itself. And so this leads to conditions like anemia, thrombocytopenia, and leukopenia, as now we don't have those different blood elements in circulation. They're just kind of trapped within the spleen itself, and the spleen gets bigger and bigger and bigger. And another potential complication of portal hypertension is the development of portosystemic shunts. And portosystemic shunts can lead to something called esophageal varices. And so again, these are like little collateral channels. These are new blood vessels that are formed in response to all of this elevation and pressure. And they usually develop between the portal vein and other systemic veins that supply blood to things like the esophagus. Okay. And this gives rise to something called an esophageal varices. So you can see that here. Here is the portal vein itself, and coming off the portal vein is the coronary vein, or the gastric vein, that supplies blood to the stomach and to the esophagus. And as blood starts to back up, it creates all of these little kind of collateral or shunting vessels. That's what you see here. And blood backs up into those. And these new vessels are usually really, they're very fragile, and they can break really easily, but they start to just fill up with blood and expand. And these varices within the esophagus itself can rupture. And if there are enough of them with all of this really rich blood supply, they can lead to massive hemorrhage. And sometimes that hemorrhage is so severe that it can be fatal. And this is further complicated by the fact that patients in liver failure often have a depletion of coagulation factors. So they bleed much more quickly and more readily, and really cannot clot effectively. So variceal hemorrhaging, or the hemorrhaging of esophageal varices, is probably the most devastating portal hypertension related complication that we see in patients with cirrhosis. It can occur in up to 30% of people with liver failure during the course of that illness. And the mortality rate for people who have esophageal varices hemorrhaging is about 20%. So a very potentially fatal complication of liver failure. So with treatment of varices, one of the primary measures that we use is preventative measures, which are often pharmacological means to try to lower portal pressure, to reduce the size and the development of esophageal varices in the first place. So we can use things like maybe diuretics or beta blockers that can reduce portal hypertension from the start. If someone develops an acute hemorrhage, we can control that as well with maybe some medications like vasopressin to reduce portal pressures. But often we use like kind of mechanical methods to stop that bleeding. So one method might be something called balloon tamponade, where we insert something into the esophagus and inflate a balloon to kind of press on or kind of occlude those bleeding varices. So balloon tamponade provides compression directly onto the varices. We can also do endoscopic sclerotherapy. You can see that kind of right here in the picture. This is sclerotherapy, where we put a scope down through the esophagus and we inject these kind of what we call sclerosing solutions directly into the varices, and they obliterate that vessel lumen. So it kind of fills it up with this sclerosing solution and kind of clots them off in a sense. We can also do something called vessel ligation. This is vessel ligation right here. We kind of go in with a scope as well, and we take these like almost rubber band looking items and like kind of just like wrap them around the varices with the scope to try to like ligate or close them off, and it kind of kills off the varices. So those are some potential more invasive treatments. In extreme cases where we can't get rid of those varices or stop that bleeding with some of these less invasive things, we can even do esophageal transection, where we take out portions of the esophagus to remove the varices with them. After hemorrhage, we also want to prevent any further bleeding. And so that the treatment there really further aims to reduce the portal hypertension and try to divert blood away from those varices. So we want blood to go someplace else other than shunting itself back into those esophageal varices. So some of the things we might do here surgically are something called a TIPS procedure or a surgical portosystemic shunt. So again, remember that what happens in portal hypertension is that the liver tissue itself starts to fibrose, and so blood can't travel through that tissue as readily as it used to, and it starts to back up into the portal circulation. And so through a TIPS procedure or through a systemic shunting procedure, we create these kind of new shunts or new ways for blood to travel through the liver. So you can see that here, this is a stent placement. So it makes kind of this new pathway for blood to flow through that fibrosed liver tissue. So that's something that we do usually in cases of, really late stage liver failure, where we haven't been able to control that portal hypertension in any other way. Because the problem with these shunting procedures is it leads to things like increased incidence of like encephalopathy, because none of the blood transferring through these shunts is being filtered at all. So a lot of patients right after these procedures can get encephalopathic, or other things can kind of happen as toxins further build up in the system. But again, it can be really helpful for a patient who may alternatively develop fatal bleeding from an esophageal varices. And so then let's go back over a lot of like all of the kind of things that can happen to a patient if they're in liver failure. And we break those up into two kind of large categories. Some of them are disorders of synthesis and storage functions, and some of them are disorders of the metabolic and excretory functions. So with synthesis and storage, again, we have hypoglycemic events because we're not able to synthesize glucose. We have hypoalbuminemia that leads to edema and ascites, and decreased coagulation factors, which lead to bleeding because of the lack of the ability to synthesize proteins in the liver. We get an increase in lipoprotein and cholesterol synthesis issues. This leads to a decrease in cholesterol. And we lose our ability to synthesize and store bile salts. And so that leads to impaired fat absorption. So we get deficiencies in all of our fat-soluble vitamins. And we also get that condition called steatorrhea, or fat in the stools. And the disorders of metabolic and excretory functions, we get an overall inability to metabolize and excrete amino acids. And this impairs the conversion of ammonia to urea. And ammonia starts to build up in the system because it cannot be excreted, and that causes encephalopathy. We are not metabolizing and excreting steroid hormones, so they start to build up in the system. So that leads to things like an increase in overall aldosterone levels. That leads to edema and ascites, and an increase in androgens and estrogens in the system, which leads to gynecomastia and testicular atrophy in men, and menstrual irregularities in women. We also are not breaking down drugs as we normally do, so drug interactions and toxicities increase, and we can't metabolize and excrete bilirubin, and that leads to hyperbilirubinemia and jaundice. So with treatment of liver failure, one thing is eliminating the underlying cause. So if liver failure is being caused by alcohol intake, then the patient needs to stop drinking. We also need to closely watch patients in liver failure for infections. So they're very susceptible to infections, so we need to be very careful to prevent infections in those patients. We also have some nutritional support that we use in the treatment of liver failure. These patients often need sufficient or higher levels of carbohydrate intake and an overall increase in calories, because this prevents further protein breakdown in the body by making sure that we're providing energy from other sources, so we don't have to break down any remaining proteins in the body for energy. We also do a significant amount of correction of fluid and electrolyte imbalances in these patients. And we also want to take measures to decrease the production of ammonia in the GI tract, and we often do that by decreasing the overall protein intake for these patients. And a final step might be liver transplantation if end-stage liver disease occurs. We're going to move on from the liver now to the gallbladder, another important structure in that hepatobiliary tree. So the gallbladder is a distensible, meaning it can stretch, pear-shaped muscular sac that's located on the ventral surface of the liver. And its function is to store and concentrate bile. So bile is produced in the liver, and then it travels out of the liver and is stored within the gallbladder. So this is what that looks like, the different components of the hepatobiliary system. So we have the gallbladder that's kind of right here, and we also have leading to the gallbladder the left and right hepatic ducts. And so those are the ducts that drain bile that's produced in the liver, okay? And they come together to form what we call the common hepatic duct, which you see right here. And then the gallbladder kind of comes off of that, and it is fed from the common hepatic duct by the cystic duct. So the cystic duct branches off the common hepatic duct and sends bile to be stored into the gallbladder. And then the common bile duct right here is formed by the union of the common hepatic duct and the cystic duct. So those things join together and then further travel down into the common bile duct, which empties itself directly into the duodenum in the GI tract. And so here's the pylorus, and the stomach, if it was in this picture, would be right here. The pyloric sphincter empties your stomach contents into the duodenum, and then usually stimulated by eating food, once that starts to enter the duodenum, then the gallbladder contracts to send stored bile through the cystic duct into the common bile duct, where it's emptied out into the duodenum to carry out its functions related to like fat emulsification in response to food. So again, entrance of food into the intestine causes the gallbladder to contract, and the sphincter of the bile duct to relax so that that stored bile in the gallbladder is then moved into the duodenum. So it kind of like contracts and squeezes that bile out into the duodenum. Okay. So one of the things that can go wrong in that gallbladder system is the development of what we call gallstones or cholelithiasis. So there are two primary factors that contribute to the formation of gallstones. One is an abnormality in the composition of the bile, particularly if we see a significant increase in the amount of cholesterol in the bile. And this can also be formed if we have stasis of bile within that system. The formation of cholesterol stones, which again is the primary way this happens, is associated with obesity. So people who are overweight tend to develop gallstones more often. People develop pain when those stones start to obstruct the flow of bile out of the gallbladder, and that can also cause inflammation within the gallbladder itself. The pain is usually in the right upper quadrant, or it can be epigastric. Sometimes it radiates maybe to the back. And it's usually, in the case of gallstones, abrupt in onset, and then it usually gradually increases in intensity and lasts anywhere from about 30 minutes to about 5 hours in duration. Another potential complication, largely because of gallstones, is acute and chronic cholecystitis. So cholecystitis is inflammation of the gallbladder, and it's usually caused by outflow obstruction. So here's my little gallbladder, and I've got a gallstone that has lodged itself in the cystic duct, which provides the outflow of bile from the gallbladder. And so remember that the gallbladder is a muscular kind of structure that is built to kind of squeeze bile out in response to food. But now we've got this obstruction, and so we're getting this significant increase in pressure within that lumen of the gallbladder. It becomes really distended. It can cause edema of the gallbladder wall, and it causes inflammation. This leads to an acute onset of upper right quadrant pain. The pain may appear with remarkable suddenness and is often a surgical emergency. If someone doesn't seek medical attention for that pain, the attack usually subsides maybe within 7 to 10 days. Other signs and symptoms that we may see are fever, anorexia, nausea, and vomiting, elevated WBCs, elevated liver enzymes, and elevated bilirubin. In chronic cases, chronic cholecystitis, this may cause an intolerance to fatty foods because now we don't have the action of bile to help emulsify our fats. Patients may get like kind of this ongoing chronic colicky pain. They may belch more. Gallbladder disease is usually treated by removing the gallbladder. The gallbladder, again, stores and concentrates bile. And so its removal usually does not interfere with overall digestion. You're still producing bile. You're just not storing and concentrating it. Laparoscopic cholecystectomy is really the treatment of choice for symptomatic gallbladder disease. And another potential complication of gallbladder issues is cholangitis. So cholangitis is inflammation of the common bile duct. So remember, we have the cystic duct and the hepatic duct that come together into the common bile duct. And if that becomes inflamed, we call that cholangitis. So it can be acute cholangitis where we get maybe a bacterial infection of the biliary tract, usually as the result of obstruction. And so then we get invasion of bacteria kind of backing up from the duodenum into that common bile duct. So that causes acute cholangitis. A complication of acute cholangitis is something called acute suppurative cholangitis, and that's kind of depicted over here. And that is when we get this development of purulent fluid within the common bile duct. So acute suppurative cholangitis is the presence of pus in the biliary ducts, and it results in something called Charcot's triad, which is jaundice, fever, and right upper quadrant pain. It can also cause things like altered sensorium or confusion, and it can lead to septic shock. So we may see significant hypotension in this patient. This is also an endoscopic or surgical emergency. This acute suppurative cholangitis needs to be treated immediately. Now we're going to move on from the gallbladder to the pancreas, and we're going to start by talking about acute pancreatitis. Acute pancreatitis is a reversible inflammatory process that's caused by premature activation of pancreatic enzymes. So the process is thought to begin with the activation of a pancreatic enzyme called trypsin. And once trypsin is activated, it then goes into this cascade where it activates a variety of our digestive enzymes. And digestive enzymes are something that is a very important item produced by the pancreas. But the point of the pancreas producing these digestive enzymes is that they then should travel through these pancreatic ducts and empty themselves into the duodenum where they can start to break down food. And so in the case of acute pancreatitis, instead of those things being emptied into the duodenum where they start to break down proteins, they're prematurely activated while they're still inside of the pancreas. So they actually start to digest the pancreatic cells themselves. So this causes, again, that autodigestion of pancreatic tissue, which leads to widespread tissue injury and inflammation. And this substantial tissue injury can progress beyond the pancreas and produce a systemic response syndrome, leading to, in some cases, multi-organ failure. Most cases of acute pancreatitis are caused by either gallstones. Those cause biliary tract obstruction that then leads to pancreatic duct obstruction and then biliary reflux that leads to that premature activation of enzymes in the pancreatic duct system. The reason why alcohol leads to this premature activation of things like trypsin is really not largely understood, but it is definitely a major mechanism of development of acute pancreatitis. So clinical manifestations, diagnosis, and treatment of acute pancreatitis. So about 20% of people who develop acute pancreatitis have a really severe course, but the rest have a more kind of mild to moderate course of disease. Onset is usually hallmarked by abdominal pain. We see this in basically all cases of acute pancreatitis. The pain is usually epigastric or periumbilical behind the umbilicus, and it often radiates to the back, the chest, or to the flanks. We may see, but not always, we can see things like fever, tachycardia, hypotension, severe abdominal tenderness, respiratory distress, and abdominal distension. And we often see elevated serum markers of inflammation, like an elevation in C-reactive protein. In patients with more severe courses of acute pancreatitis, we might see clinical findings like thirst, poor urine output, progressively elevated tachycardia, tachypnea, hypoxemia. They may become agitated and confused. Their hematocrit levels rise. And if we don't see an improvement of those kind of more severe symptoms within 48 hours, those are warning signs of impending really severe disease in acute pancreatitis. Acute pancreatitis can also cause further complications like a systemic inflammatory response. It can lead to acute respiratory distress syndrome or ARDS. It can cause acute tubular necrosis with kidney failure. It can cause multi-system organ failure. It can also cause an overwhelming infection from from a condition called acute necrotizing pancreatitis. So the all that tissue damage that we're seeing in the pancreas, it can start to necrotize or die, and that can lead to infection of that tissue. And we also see this large volume fluid collection around the pancreas and into the abdomen. So we get these kind of big shifts in fluid as well during acute pancreatitis. Diagnosis includes the presence of 3 different markers. One is that characteristic abdominal pain that we talked about. The other is elevated liver enzymes, specifically serum amylase and or lipase, and they need to be about 3 times or more their normal upper limit. And then the final characteristic in diagnosis is some characteristic finding on either ultrasound or CT or MRI that's consistent with acute pancreatitis. Treatment really depends on the severity of the disease, but we often require hospitalization in acute pancreatitis. We often withhold food and fluid because eating and drinking further stimulates the release of pancreatic enzymes, and that makes the condition worse. So these patients can't eat or drink. If this persists, we need to give them fluid intravenously, and we may need to give them total parenteral nutrition to support them. And we also need to restore plasma volume that can be lost when all of that fluid kind of shifts and collects into the abdomen. We also may do gastric suction to remove anything from the gastric or from the stomach that could further induce release of pancreatic enzymes. Again, we give IV fluids. We see a lot of electrolyte imbalances in patients with pancreatic disease. There's a lot of cellular breakdown, so it releases things like potassium and magnesium into the system. And they often need the administration of colloids or proteins to help pull and keep fluid in the vasculature so it doesn't third space into the abdomen. Chronic pancreatitis is a persistent chronic inflammation of the pancreas, and it leads to progressive destruction of the pancreas itself. And one of the big differences between chronic and acute pancreatitis is the destruction of pancreatic cells that we see in chronic pancreatitis is not reversible. This is most commonly caused by alcohol abuse. And people experience episodes that are similar to what we see in acute pancreatitis as far as clinical manifestations, but they're usually far less severe. And they're often precipitated by an event like overeating or chronic alcohol abuse. You can see in the picture that the chronic inflammation of that pancreas is causing fibrosis of the tissue, calcifications, and atrophy to occur so that that pancreas is becoming destroyed. And so these patients develop things like diabetes because they can no longer produce the hormone insulin. They also get malabsorptive disorders because they are no longer producing the digestive enzymes that we usually produce in the liver. So they get difficulty with digestion and absorption of nutrients, especially things that contain fat or fat-soluble vitamins. They often experience things like abdominal pain that gets worse when they eat. They get steatorrhea or those fatty stools. They often lose weight. When we're treating chronic pancreatitis, we may make dietary changes like instituting a low-fat diet. We can give pancreatic enzymes orally, especially when people eat, to help reduce that overall malabsorptive syndrome. Patients may need insulin supplementation if they stop making insulin. We ask patients, of course, to abstain from alcohol. We may need to give narcotic pain medications to control that kind of chronic pain related to pancreatitis. In severe cases, especially cases that maybe are caused not by alcohol, but maybe by obstruction, especially of the pancreatic ducts, we can maybe relieve that obstruction with surgery to help reduce overall symptoms. And the final thing we're going to talk about is pancreatic cancer. The major cause of pancreatic cancer is really unknown, but we have a lot of different risk factors associated. Smoking appears to be the most important of those risk factors, but other things are age, alcohol intake, obesity, the presence of diabetes. Pancreatic cancer is more common in men. It's also more common in patients with chronic pancreatitis. There are some hereditary factors that have been found. This disease rarely occurs in anyone under the age of 50, so again, age is a significant factor. Um, Patients with really high caloric intake are also at higher risk, especially if that intake includes high intake of fat, meat, salt, any dehydrated kind of or processed foods, fried foods, refined sugar, high levels of soy, or nitrosamine content of food. The thing about pancreatic cancer is its 5-year survival rate is very poor. Even patients with early stage pancreatic disease have relatively poor outcomes. And so people with stage 1 or kind of more early stage pancreatic cancer still only have a 13% 5-year survival rate. Stage 2 is about 6%. Stage 3 is about 3%. And stage 4 pancreatic cancer, its 5-year survival rate is only 1%. The other thing with pancreatic cancer is it's largely asymptomatic. And so for most patients, they don't become symptomatic and we don't find pancreatic cancer until they're usually into some of those later, like stage 3 or 4 points of disease progression. So this is a cancer diagnosis that has a very poor prognosis.